We have our next presenter. Uh, Complications management is very important in the flap. So, Dr. Rajesh Sinha, we all know him. He is a excellent surgeon and excellent person. He'll be talking on top 3 flap complications and management. Dr. Sinha, please.
Thank you, Dr. Ajay. The topic that I was given was top 3 LASIK flap complications. Well, it was difficult to decide which are the top 3. There are so many. But then I thought that I'll focus on flap buttonhole and, of course, flap stria and epithelial ingrowth, which can happen because of various factors related to the flap. And so flap buttonhole more often is seen with a microkeratome where there is a buckling, as was being discussed by Dr. Sonu, that in a very steep cornea, you can have flap buttonhole. And it's a very old video of flap buttonhole wherein we did have this thing in a steep cornea. If you have a flap buttonhole, you have to defer the surgery and do a recut. Later, you can do a microkeratome LASIK in this with a larger cut and going deep, and or you can do a surface ablation as well if you want to do it a little earliar. Femtosecond LASIK, in that also you can have vertical gas breakthrough, which is very uncommon, but yes, it can happen. In that case, again, you have to wait for a couple of months, and you can go ahead and do a surface ablation easily with in all these cases. So I'll just move on to the next one. The next is flap stria. Now, flap stria can be seen if you are ablating quite a lot, wherein again, what happens that you tend to keep a very thin flap, and in such cases, the risk of flap stria is there, particularly when, sometimes when the patient rubs the eyes or there is some trauma, etc. In that case, it can happen. Now, if you have a flap stria, then you have to refloat it. Do an ironing. But whatever you do, I think ironing, etc., it does help. But what in our clinical practice, and I think even in studies, they've shown that unless you, debride the epithelium and swell the stroma of the flap stria don't disappear in large majority of cases. Maybe on day 1, if there is a flap stria, you can just refloat and it can go off. But if you have a case wherein it's a 1 week old, etc., then in that case you have to debride the epithelium and hydrate it with hypotonic saline, or if you don't have hypotonic saline, you can use simple distilled water, which is there in every operation theater, and that swells up. The idea is to swell the stroma of the flap so that the flap stria disappear, and it works very well. Sometimes you can have a trauma, like in this case, the patient had a trauma, and then you can see the flap from here has moved, so it is a dislocated flap with flap stria, and there is epithelial ingrowth as well. As you can see in this photograph, there is presence of epithelial ingrowth. So in such a case, again, you have to lift the flap, and once you lift it up, debride the epithelial ingrowth, whatever is there. And then, of course, one should use mitomycin C in all these cases because you cannot be 100% sure that all the epithelial cells have been removed. So it is essential that you should use mitomycin C 0.02% for 45 seconds to 1 minute, depending upon your choice. You can do ironing of the flap, and then once you have done, you can do ironing, and once you have done that, you debride the epithelium, put some hypotonic saline or distilled water on the surface so that the stroma of the flap swells up so that it stretches, and that's how it takes care of the flap stria. This is the post-op picture. There's no flap stria in this. Epithelial ingrowth is another very important issue which can happen because of improper flap, because of various reasons, because of the flap dislocation, because of in hyperopic LASIK it is more often seen because the ablation is in the periphery, so the flap edge apposition is not that great, so that is possible. You can see here, you can have a very small epithelial ingrowth. The area of entry is here. Here, if you put a small drop of fluorescein, you will get a stain. And that shows that the adhesion or the apposition of this flap at this point is not good, and that is why epithelial has gone in. You can have a bad epithelial ingrowth which is in the center. This was the epithelial ingrowth in the center, not coming from the flap edge. So we were just wondering why it happened. It happened because there was a flap buttonhole. You can see there's a thin scar here at the edge from where the epithelium is going in. The incidence is not very common, and with the femtosecond laser, the flap edge, if you create a good flap edge, the risk of epithelial ingrowth is not very high. But in cases of EBMDs, like epithelial basement membrane dystrophy, you have higher chance in case of diabetes, wherein whenever there is risk of loss of epithelium, the risk of epithelial ingrowth is high. As studies have shown that it's very high in hyperopia. And once you have an epithelial ingrowth, you lift the flap, and then you debride the epithelium, put mitomycin C, as I showed in earlier picture. But sometimes you can have a very bad epithelial ingrowth, which, if you see in this case, this patient was operated 11 years back outside this country. A prisoner came to me with this much of epithelial ingrowth. And when we did ASOCT, we found out that the epithelium was actually entering into the flap. It was difficult to remove it from the flap as well. And if you debride the epithelium, just debride it, it is, whatever you do, it will come again. In such cases, flap amputation should be done, because the risk of recurrence is very high. And with flap amputation, the only fear that people have in mind is that how much will be the refractive error? It is not much. In most of the studies and in our own experience as well, the hyperopia is hardly anything. You can get little bit of astigmatism, mainly more often because of the microkeratome flap, because in such cases, what happens that if there is any surface irregularity, the interface irregularity is also there, and that can result in some astigmatism. So you do a flap amputation, and I'll just move fast because of paucity of time, and then use mitomycin C. And this is the post-op picture. It's clear, and the patient has plus 0.75 diopter sphere and plus 0.75 diopter cylinder, and he is 6'6". Now, as I showed in one photograph, this was a case of a flap buttonhole, wherein you can see the epithelial ingrowth has not come from the periphery, it has come from the edge of the flap buttonhole. And then in that case, you have to lift the flap, and once you lift it, as you can see, I'll just show, this is the edge of the flap buttonhole. You can see it's coming out, and then you can, even after a very long period of LASIK, you can still lift the flap. But in such a case, if you have a flap buttonhole, it's better to amputate the flap, because if you replace the flap, it is not going to help at all. Again, there will be epithelial ingrowth. So I'm using alcohol, debriding the epithelium, and then with the help of a lamellar dissector, this island of stroma has to be removed. Now I'm just removing the epithelial ingrowth, and with the help of a lamellar dissector, I'm removing this island of stroma. And once it is removed completely, put mitomycin C, and then put a bandage contact lens after washing it thoroughly. So studies have shown that the results are good. Just 30 seconds more. This is a case wherein there was epithelial ingrowth in the periphery. There's a standard teaching. We all follow that if it's in the periphery, don't do anything unless it is causing high astigmatism, unless it is creating problems. And in this case, there was a flap melt because of the elevation of the flap because of epithelial ingrowth. Then again, flap amputation was done. And in this case, I have done a superficial anterior lamellar keratoplasty in this, replaced a similar thickness of donor lenticule. But doing both, what I have noted is that even if you do a flap amputation only, there's hardly any refractive error. So in conclusion, LASIK flap complications can be seen more often with the microkeratome and also with the earlier generation of microkeratome, more often seen with any abnormality in the cornea, if it's very steep, very flat, hyperopic, LASIK, etc. And depending upon the situation, we have to manage accordingly. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. You talked about flap amputation. So is there any limitation to the thickness of the flap where you can amputate, or maybe some thin flaps can be done?
See, most of the times these complications, like the flap buttonhole that was there, it was a thin flap only, and it can be amputated. But most of the times, these days, we hardly create a flap of 100 micron or a 90 micron or 110 microns, even if you are using femto or you are using microkeratome. So if you remove that flap, if you amputate the flap, it doesn't cause, it doesn't, actually it has been seen in studies also, and we have also noted that it is not the mathematical calculation that if you remove 100 microns, it will be about 100 divided by 15, and that much of a refractive error will be there. Most of the studies have shown that it is plus minus 1 diopters, 1.5 diopters, not more than that. Just one point has been noted, that there is some degree of astigmatism, particularly in microkeratome LASIK. Why? Because they have shown that probably the interface is slightly, there are some crypts and some elevations which are compensated when you put the flap.
Right.
But when you remove the flap, those crypts and elevations are exposed, and that is why you get some astigmatism. And in invariably, most of the cases, or all the cases, you get some astigmatism, but that is also about 0.75 or so.
Thank you.
So, thank you, Rajesh. Just a quick question for the benefits of the audience. So what is the concentration of mitomycin C and alcohol that you would advocate, in patients with epithelial ingrowth, or, which is your preference?
Alcohol, I use 20%, and mitomycin C 0.02%.
And what is the duration?
Alcohol, when I'm using for, say, PRK, etc., I will use it for 30 seconds. But when I'm doing it for an epithelial ingrowth, I'll use it a little longer, maybe 45 seconds. And for mitomycin C, again, I will use 45 seconds to 1 minute.